Dr. Asbell, thank you so much for meeting with us today. There was a special symposium at the ARVO 2017 meeting about antibiotic resistance, and you were invited to speak about a particular topic, the role of surveillance studies in understanding antibiotic resistance, looking at U.S. trends. Can you give us an overview of that presentation?
Sure, Jolie. Thank you for inviting me to Ophthalmology Times. You know, this is an important topic. Sometimes in ophthalmology we think, well, we have so many eye drops, we can use one of them, and most times they do work well. However, when you look at this topic worldwide, it's estimated by the year 2050, over 10 million people will actually die as a result of problems from antibiotic resistance. And if you compare that with something like cancer, cancer is only 8 million, still a serious problem, and diabetes is maybe 1 million. So we're seeing an awful lot of problems worldwide from antibiotic resistance, and that's why it's an important topic that we ought to know something about, not just in general medicine, but in ophthalmology as well. You know, in the United States, the CDC has put together a lot of data about antibiotic resistance. They kind of keep tally on trends and what's going on. In the United States, the CDC has reported that there have been over 2 million illnesses in 2013, specifically related to antibiotic resistance, and nearly 23,000 deaths. So it puts in context, not just for the world, but for the United States as well. When you look at the eye infections, there are kind of two areas that we're interested in. One is infections of the cornea, keratitis, and something that's been growing a lot is the ability now to treat macular degeneration with intravitreal injections. Fortunately, endophthalmitis is rare, whether it's after cataract surgery or intravitreal injections, but you know, we do so many of them. Cataract surgery in the United States is about 3.5 million surgeries a year, and they estimate over 20 million worldwide. Intravitreal injections in the United States in 2013 were over 2 million, and that number is growing. So yes, the complication rate is low, but it's not zero, and these people end up with devastating vision loss. There actually were several posters at ARVO talking about the vision loss related to serious infections in the eye. So we want to treat them as well as we can, and that means picking the right antibiotic. And what's happened over the last decade or two is we've seen a marked decrease in the availability of new antibiotics. There's just a dearth of them, new opportunities for treating. So we have to take the ones we do have and use them as wisely as possible. Surveillance studies have a key role in understanding antibiotic resistance. One, it determines what's going on. Unless we do the study, we really don't know. Two, we learn about trends or their changes over time. And perhaps most important for the clinician is figuring out how to initially pick the right antibiotic. Because here you are, even if you are going to do a culture, you don't have the results on day one. So these surveillance data can give you an idea of how best to pick wisely for suspected organism. One of the things that we found in the past is single center, small studies. They may not have the statistical power to really give us the right information, and they may be sort of geographic differences that don't necessarily apply to your patient base. So the goal of a surveillance study is doing multi-site investigations from across the United States and maybe even globally to look at trends across a wide variety of patients, wide variety of geographic contributions. When you do surveillance studies, we don't look at every infection that ever occurred. That is one way to do it. We generally pick the ones we think are most important, in this case for eye infection. And we looked at studies, more than half of eye infections are usually gram-positive organisms. And the ones that are most commonly seen are Staph aureus, coagulase-negative staph, other gram-positives, and then we're always concerned about Pseudomonas because it causes such serious infections. So two of the major surveillance studies done in the United States is Ocular Trust, tracking resistance in the United States today, and the ARMOR study, which is Antibiotic Resistance Monitoring in Ocular Microorganisms, which was initiated in 2009 and is still ongoing. So these are the two big surveillance studies that I recently reviewed at this ARVO meeting. The key about the surveillance studies is its multi-site involvement. We did sites all across the United States. The isolates are collected and sent to one reference laboratory that does the analysis. So there's very uniform information about these isolates, and it doesn't vary by which laboratory or which person is doing the evaluation. So when you look at Ocular Trust and ARMOR, we evaluated over 5,000 isolates. In Staph aureus, the key finding is 38% were methicillin-resistant organisms. In coagulase-negative staph, nearly 50% were methicillin-resistant. So we're seeing a large number of organisms that are resistant to some of the common antibiotics that we typically use. In strep pneumoniae, 34% were resistant to azithromycin. And the resistance is primarily one that we're concerned about is the methicillin staph resistance. When you look over the trends over the year, we actually see a little positive information, meaning we still see that resistance, but it is slightly decreasing over time. Not a whole lot, but just a little bit, suggesting maybe we've reached the peak on the number of cases and percentage we're going to see in methicillin resistance. But there's a big take-home message here. One is, yes, the resistance may be slightly decreased, but we're still talking about 40% of the organisms collected were resistant, so it's still a significant number. In strep pneumoniae, most antibiotics that we use in the eye work well, but azithromycin saw a 2 times increase in resistance over this 10-year period that we've been evaluating. So this is still an issue of concern when you're picking an antibiotic. One good news is vancomycin still works very well against the methicillin-resistant organisms. If you look at the overall survey or the summary of these 2 studies, the ARMOR and the TRUST study, you do see that resistance among staph has remained high. Methicillin resistance continues to be high, though there's a tiny decrease over time. Strep pneumoniae, as I mentioned, it's doubled against resistance against azithromycin. And surveillance, well, going forward is the only way we're going to know whether this is staying stable or changing. I think one of the other key take-home messages is about multi-drug resistance. So if something is resistant to methicillin, there's a good chance it's going to be resistant to 3 or more other antibiotic classes. In fact, nearly over 70% of the Staph aureus are going to be multi-drug resistance. The coagulase-negative staph, the same thing. Over 70% are going to be methicillin, not only methicillin resistant, but resistant to 3 other antibiotic classes. So it's going to be hard to choose that other antibiotic to pick wisely to treat these patients. One of the things to keep in mind about surveillance studies is it's looking at the organism in the laboratory in vivo, and it's the interaction of the microorganism, the growth media, and the drug. However, when we're talking about how it works in people, we're looking at the interaction of the organism, the antibiotic, and people. So we have a much more complex system we're looking at. One of the other issues is, in terms of deciding if something is resistant or sensitive, we're using breakpoints that have been developed for systemic treatment by the NCCLS, the National Committee for Clinical Laboratory Standards. Those work well for systemic treatment. We don't have such breakpoints for ocular treatment. And it's one of the reasons why reporting MICs may be helpful in choosing antibiotics, because you can look at the actual numbers to determine maybe which antibiotic is going to work best in a specific situation. Again, when we're thinking about an antibiotic choice, we're thinking about broad spectrum. That's what the survey and the Ocular Trust and the ARMOR tell us about. We also want to know about bioavailability and biocompatibility and safety. So keep those issues in mind too when you're picking a surveillance study and the information that you're going to use for selecting an antibiotic. Now, surveillance studies do have their issues. There's selection bias. In eye disease, we typically only culture when it's a severe infection. We mentioned that the breakpoints for resistance are from systemic information, not from ocular treatment. And in vitro, the laboratory data do not necessarily equal what we get in clinical practice in patient care. And we don't collect all isolates. We're still a large number, but it's not every isolate that has ever been collected on eye disease. Some people say, your trends say there's not that much change over the last 10 years. In fact, you said that the MRSA rate is slightly improved. There's a little less, still significant, but a little less. And you say, do we really need to keep doing this? Well, think about something like blood pressure. We don't take the blood pressure 1 year, say it's normal, and never come back. We do that on a regular basis because we never know when somebody's going to turn up to have elevated blood pressure that requires treatment. And that's what surveillance studies are about. Understand the trends, use that information to wisely pick your first antibiotic for treating an eye infection, and looking at that information going forward to see what we should be doing to change maybe our treatment patterns, or maybe even understanding the pathogenesis with a particular organism that will better help us treat patients. So it's an important element that all of us as clinicians are going to use wisely to help our patients do as well as we possibly can.
And kind of as a last nugget for the clinician, is there anything from this study that you would say they could implement in their practice right now?
Well, I think the main take-home message I'd like to say is not every antibiotic works well all the time. So we do have to put some thought into selecting it. And I think looking up some of this surveillance information, which is publicly available, even looking up if you're working in a specific hospital, they publish surveillance data on their hospital on a yearly basis. Use that data. It's there for a reason. Use that. You can get it online, and you can make a wise choice about what's going on. And then also a wise choice on the potential second antibiotic choice if somebody is not doing well on the first initial treatment. So I think it should be useful to clinicians on an everyday basis.